Earlier today, Olivia Munn shared that she had been diagnosed with breast cancer, so let's talk about it. I am Dr. Eleanor Chaplinsky. I'm a board-certified medical oncologist specializing in the treatment of breast cancer. Olivia shared that she had had negative genetic testing, meaning she didn't inherit a mutation that increased her breast cancer risk. She had had a normal mammogram, but was diagnosed with breast cancer 2 months later. And the reason that she was diagnosed was that she had sat down with her doctor to calculate her breast cancer risk. And because her lifetime risk of breast cancer was calculated to be greater than 20%, she was recommended to have an MRI, which found her breast cancer. So let's break that down a little bit. Current guidelines recommend that all patients starting around the age of 25 and to 30 sit down with their doctor to talk about their individual breast cancer risk and figure out when they should start screening and with which modalities. And there's, this is essentially a conversation about your risk. It's based on your personal history, your family history, if you have a genetic mutation, if you've had prior cancer, prior radiation to the chest. There's a number of ways and tools available to figure this out. One of the tools that we use often is the Tyrer Cuzick model. It's also known as the IBIS II model. It's publicly available, and you go in and you plug in all your information, things like your current age when you started getting your menstrual periods, age at menopause, age at your first child's birth, your age, your breast density, if you have a genetic mutation, if you've had a prior biopsy and what that of the breast and what that biopsy showed, your family history. It's pretty comprehensive, and it gives you your 10-year risk and your lifetime risk of getting breast cancer. It's not perfect, but it's something. And if your lifetime risk is greater than 20%, guidelines recommend having this conversation about adding supplemental imaging, either with MRI most often or with ultrasound, depending again on your risk, to your mammogram. And so when we talk about starting mammograms at the age of 40 and getting them once a year, that's for people that are of average risk. And so this is a way to figure out if you are at higher risk, and then how often should you be getting testing, when should you start, and with which modality. Olivia also shared that she'd been diagnosed with luminal B breast cancer. So what is that? There's essentially 4 subtypes or molecular subtypes of breast cancer. The hormone receptor positive breast cancers tend to more likely be luminal A or luminal B, which is what she had. HER2 enriched, those are HER2 positives, and then basal-like or triple negative. And there's overlap between the categories. But luminal B breast cancers tend to have lower expression of hormone receptors compared to luminal A. They tend to have higher proliferation markers like Ki67 and tend to be of higher grade than luminal A. So they are more aggressive. They tend to grow faster, and the prognosis can be worse than those of luminal A subtypes. I really commend Olivia for sharing this information and opening the conversation about breast cancer risk assessment. And I think it's important that her story and her post should not inspire panic or fear. It should not inspire people to think that I had a negative mammogram and is that enough? Oh my gosh, I may be missing something. But rather, I hope that it inspires people to have that conversation with their doctor about their individual breast cancer risk and should they be getting supplemental imaging. I would love to know comments, questions, your thoughts on this. Let me know.